exciting panel of witnesses. We hope, in working with Energy and Commerce, that we can combine their jurisdiction over Medicaid with our jurisdiction over Medicare, and at the end of the day to make certain that no one falls between the cracks as we move on with the President's wish, desire, mandate that we have quality care, lower cost, and maximum coverage for everyone. Today we will be concentrating on the employer-sponsored insurance and making certain that we recognize how important it is and that we do everything to strengthen it. And as the President says, if you like what you got, we're not thinking about doing anything except trying to lower the cost across the board. We want also to make certain that the private insurance plans do take the high-risk people, that the preconditions are not an issue, and we will be entertaining the question of employer mandate. We will be entertaining the question of a public plan. All of these things will be discussed. And so, again, sometimes on our side, David, we believe that the hearings is the best that we can do, but it's almost not fair to the witnesses to prepare and then have 5 minutes and just the questions. But we do hope all of you would make yourselves available if we have a round table where we don't have the 5 minutes, where you can expand on your visions as to how we can make a healthier America. I'd like to yield at this time to Mr. Camp.
Well, thank you for yielding, Mr. Chairman. And before I make my opening statement, I just want to take a moment and recognize the Chairman's commitment to the issue before us, health reform in the 21st century, and his receptiveness to work together to find the right way to reform health care in this country. Last week I requested additional witnesses so that we could fully vet the complexities involved in improving both health insurance and health care. And I just want to say that the Chairman has granted the minority an additional witness. Mr. Chairman, I need not tell you there are several new members on this committee, particularly on our side as well, and this is not an insignificant act on your behalf, and I want to thank you personally very much for that. I look forward to continuing this approach to health care reform, and hopefully this will spur further bipartisan talks and negotiations. I remain confident that we can find common ground. Health care reform should not be a partisan issue. It is not a partisan issue. It's not a Republican issue or a Democrat issue. It's an American issue. It's not to suggest we don't face difficult questions. In fact, today's hearing will explore one of the tougher challenges we face. How do we protect employer-sponsored insurance and the access to affordable health care it provides millions of Americans? And today we'll hear from several employers. One of them, Denny Dennis of the National Federation of Independent Business, which represents hundreds of thousands of small businesses that typically employ about 5 people and collectively create 60 to 80% of the new jobs in America. Of particular concern to these job providers and creators is a federal mandate to provide insurance or pay a penalty. That tax, per Mr. Dennis's testimony, would harm small businesses, especially those operating at the margin, and disproportionately impact low-income workers. Others today will suggest that a government-run health plan must be a part of the solution, though such an option carries significant risks. As Mr. Shields of the Lewin Group will testify, their April 2009 study that found the introduction of a government-run plan that reimbursed providers at government-set Medicare rates would have significant ramifications for those who already have health insurance. One finding, almost 120 million Americans would lose their current health insurance coverage. Inside that data, we found that of the 120 million who lose their coverage, 108 million are those who have employer-provided insurance. A total of roughly 160 million Americans have health insurance through an employer. That means 7 out of 10 people, workers, husbands, wives, children, will lose their health insurance provided by employers due to a government-run plan. I think my colleagues on both sides of the aisle will agree that it is difficult enough to provide access and coverage for the 30 to 45 million Americans without insurance, without having to take on the responsibility of an additional 108 million individuals with employer-sponsored insurance. nor does an employer mandate which trades job creation for insurance coverage make our job any easier. Employer-provided insurance is under pressure and in many cases is already eroding. This is a trend we need to reverse, not accelerate. We need to improve upon our current healthcare system, not end it. Now, I know some in the majority have suggested Republicans are making the government run plan an issue. And as I noted last week, even the White House has said that reform does not hinge on the inclusion of this provision. And just yesterday, the Washington Post opined, and I quote, "It is entirely possible to imagine effective health care reform, changes that would expand coverage and help control costs without a public option." And the editorial went on to read in part, and I'm quoting again, "It's difficult to imagine a truly level playing field that would simultaneously produce benefits from a government-run system. Medicare keeps costs under control in part because of its 800-pound gorilla capacity to dictate prices. In effect, to force the private sector to subsidize it. Such power, if exercised in a public health option, eventually would produce a single-payer system. If that's where the country wants to go, it should do so explicitly, not by default." And Mr. Chairman, I ask that the Washington Post editorial be submitted into the record, and with that, I yield back the balance of my time. Thank you.
Without objection, Mr. Camp. In furthering an opportunity to make certain that we have maximum participation, even if we don't get maximum support, if the minority really feels that there's some things here that can be worked out, without having formal hearings, there's no reason why we cannot get experts to take a look at that, whether we use the library, H-137, or even the hearing room. But this is so important that even if you can't vote for it, we would like to be able to accommodate in terms of bringing the experts here that you might need or we might need to better understand some of the complexities that just may impede someone from wanting to receive the goal but just not being able to support a bill that has it or doesn't have it. So we'll work that out after. We have an outstanding group of witnesses, Dr. Lee Skold, Randy McDonald, Bill Pasquale from Jersey will be introducing a small businessman from his district, Kelly Coughlin, Denny Dennis, who's a research policy person from the National Federation of Independent Businesses, John Shields, is Senior Vice President of the Lewin Group, and our last witness will be Jerry Shea, who comes representing the President of the AFL-CIO. So this is going to be a good day for all of us. We'll start with Dr. Gold, who's the Director of Health Policy Research, an outstanding background, an author, a lecturer, and she will give us some views on why a public health insurance plan would be able to help us. Thank you for taking time out to share your views with us. You may proceed. As you know, we have 5 minutes more or less, and we want to give the members an opportunity to ask questions while you're here. Thank you. You may proceed.
Good morning, Chairman Rangel, Ranking Member Camp, and distinguished members of the Ways and Means Committee. My name is Elise Gould, and I'm a health economist and Director of Health Policy Research at the Economic Policy Institute. I appreciate the opportunity to appear before you today to share my views. Employer-sponsored insurance, I will call it ESI from here on out, provides insurance for the majority of under 65 Americans. ESI, particularly among large firms, works because it pools risks, has low administrative costs, and offers a stable source of coverage for a large share of the population. Many of these people enjoy the benefits they receive and would like to keep them. However, we have seen a weakening in ESI over the last several years, and it is important to examine strategies, and I commend Chairman Rangel in holding a hearing to examine strategies to strengthen ESI and find ways to provide this high-value coverage to more Americans. The employer-sponsored health insurance industry in the United States did not flourish until the middle of the 20th century. During World War II, employers offered health benefits as a way to attract workers when the National War Labor Board froze wages. In 1954, Congress amended the Internal Revenue Code to clarify and expand a 1943 administrative tax ruling that granted tax-exempt status to employers' contributions for their employees' group medical and hospitalization premiums. Excluding premium contributions from taxable income made $1 worth of health insurance less expensive to provide than $1 worth of wages. In general, this tax exemption, effectively a government subsidy, reduced after-tax insurance premiums enough to encourage even the healthiest employees to enroll. In that way, sustainable risk pools were formed and group policies became more attractive to insurance companies. Over the latter half of the 20th century, employer-sponsored health insurance became increasingly popular. Workers have grown to rely on employers to provide insurance, and employers have used it as a tool to attract and retain the best workers and improve the health of their workforce. Employment-based coverage remains the most prominent form of health insurance today. About 63% of under 65 population has insurance either through their own or a family member's employer. Over 80% of the college-educated and 80% of those in the top half of the income distribution have ESI coverage. In fact, if you break the non-elderly population into fifths by household income, we would see that those in the top income fifth are nearly 4 times more likely to have coverage than those in the bottom fifth. So we see that employer-sponsored health insurance is working well for tens of millions of American workers and their families. That said, the problem remains that many folks are left out or are ill-served by the employer-sponsored system. Further, while ESI remained the dominant form of health coverage through the 2000s, the share of people covered by ESI declined 5 percentage points since 2000. This erosion or unraveling has been occurring even during the economic recovery. During an expansionary period, we would have expected coverage to increase as employment grew, but it simply did not. High and rising health costs are mostly to blame. Average premiums for an employer-sponsored family plan have risen nearly 120% since 1999, 3.5 times faster than workers' earnings, and more than 4 times faster than general inflation. Small business owners and their workforce face particular challenges in obtaining ESI. The coverage rates in firms with fewer than 10 workers is less than half that of workers in firms with more than 100 workers. Half of all the uninsured are employed by a business with fewer than 100 workers, and 36% work in firms with fewer than 25 employees. Small firms that do offer health insurance face high costs, paying on average 18% more than larger firms for identical policies. This is due to higher and more variable health risks, a lack of competition amongst insurers, and greater administrative expenses. I know in 2007 at the small firm where I work, with less than 30 days' notice, our insurer raised rates by 27%, forcing us to switch carriers at the last minute, which is not easy in the limited marketplace. It is these high and unpredictable costs that have made it increasingly difficult for small firms to provide the insurance they want to offer their workers. So what does the future hold? The current economic downturn and forecasts of high unemployment indicate continued erosion of employer-sponsored insurance in the near future. I estimate that by the end of 2009, nearly 50 million non-elderly will be uninsured. The link between insurance and work has been a tradition in this country. ESI, particularly in large group markets, can effectively pool risk, lower administrative costs, and maintain stability. But we must recognize its limitations. There has to be a way for the non-workers, part-time workers, and even those full-time workers have been closed out of the current system to find affordable coverage. Private market reforms such as community rating and guaranteed issue can improve competition between insurance companies by ensuring that this competition takes place on the grounds of efficiency and not on companies' ability to sort the population for the lowest health risks. The best way to ensure that coverage is universally made available to those who do not have good ESI is to construct a national insurance exchange that includes a public health insurance option. A public health insurance option is an essential part of this exchange. While giving Americans more choices for coverage, it also has the added advantage of increasing competition to already limited markets, reducing costs and cost growth, driving quality advancement and innovation, and serving as a benchmark for the insurance market. As we move forward towards meaningful reform, we must be wary of quick fixes to our insurance system. One such fix involves taxing health benefits. Research shows that taxing high-priced health coverage will heavily burden 2 groups: workers in small firms and workers in employer pools with higher health risks, such as those with a high percentage of older workers. Small businesses are paying high premiums for the insurance they provide to their employees, not because the plans are especially lavish, but because they have high administrative costs and include too few employees to constitute the broader risk pool that would qualify them for lower premiums. Capping the tax exclusion exacerbates the problems small firms already have. It would encourage the young and healthy to opt out of these pools, and upon their exit, premiums would likely rise for those remaining. Instead, we should build on what works well in today's American healthcare system, ESI for the bulk of the workforce, as well as extremely popular programs like Medicare. Thank you, and I am more than happy to answer any questions you may have.
Thank you so much for your testimony. We'll now like to call on Randy McDonald, who's the Senior Vice President for Human Resources at the IBM Corporation, and is the Chairman of the Board of the Policy Association, which represents more than 250 of the largest corporations in the United States. And he is committed to providing health insurance to employees, but he's concerned, as all of us are, with the rising health care costs. So we're very anxious to get your views on how we can be helpful with our bill.
Good morning, Chairman Rangel, Ranking Member Camp, and members of the Ways and Means Committee. My name is Randy McDonald. I am Senior Vice President of Human Resources for the IBM Corporation. As mentioned, I also serve as Chairman of the HR Policy Association, a group of Chief Human Resource Officers of more than 260 of the largest corporations in America. Simply put, IBM is building smarter health systems with a more personalized experience for patients. A smart healthcare system will be better instrumented, interconnected, and intelligence-centered around the patient. IBM intends to be a leading proponent of healthcare reform because it is both a competitive necessity and because it's good business for us. We believe that broad, systemic reform is necessary. A successful agenda will build on a patient-centered, accountable, competitive healthcare market that delivers effective outcomes and improved unit cost. I must say, adding millions of people to an overburdened, underperforming system is somewhat like diverting water into the Red River while you're piling up sandbags. Change must be structured, it must be planned, and it must have incremental giant steps. IBM has 450,000 reasons to be an active participant in this national discussion. Those reasons are our employees, our retirees, and their dependents, and the fact that we spend $1.3 billion on health care in 2008 alone. Successful health care reform doesn't have to begin from scratch. Employer-based health care is a good starting point, but we need a broad-based approach to fix certain fundamental flaws, including effective incentives for wellness, prevention, primary care, better cost controls, and higher quality outcomes. Earlier this decade, IBM had double-digit cost increases. Accountability and transparency were non-existent for employee decision-making. Real cost, prices, and subsidies were actually hidden. Between 2005 and 2007, our assessment showed dramatic declines in employee health risk, including behaviors such as smoking. Participation in wellness programs rose sharply, and more adopted healthy behaviors such as exercise and good nutrition. Program costs during this period were $81 million, with a total savings approaching $200 million. Today, our employee population is healthier. Employee costs remain lower than our benchmarks. With this experience, we support a national health reform agenda with 7 recommendations. First, strengthen the voluntary employer-based system of health care. Second, adopt a comprehensive national reform agenda. Third, significantly improve wellness, prevention, and primary care. Fourth, create a competitive and accountable marketplace. Fifth, control cost, improve quality, and reduce cost shifting. Sixth, assure adoption of the healthcare information technology. And seventh, ensure all Americans have health insurance. Mr. Chairman, reform can only succeed with an approach built on shared responsibility. All stakeholders must come here with an open mind and share the burdens as well as the benefits of reform. In my written testimony and through the work of the HR Policy Association, I have detailed what we see as those stakeholder responsibilities. In sum, we believe that the crisis in American healthcare is too complex for any one person, for any one organization, or one sector of our society to figure out the best solution. We need a comprehensive solution, not a Band-Aid here or there, but a solution. The panacea in healthcare is a system that does more than just deliver quality care, at reasonable cost. Our aim should be to make all Americans healthier and our economy stronger. Thank you.
Thank you, Mr. McDonald. And we'll make certain that whatever we move forward, we don't hurt what's already working for IBM and for America. So thank you for your contribution. Mr. Pasquale wants to have the honor of introducing, where's Bill? Yes, a member, outstanding member of his community. I yield to Congressman Pasquale.
Thank you, Mr. Chairman. I'm proud that we have on our panel today Mr. Kelly Conklin, who both lives and works in my district. Mr. Conklin is the co-founder of Foley Waite Associates, an architectural woodworking company in Bloomfield, New Jersey. He and his wife, Kit, and business partner, started their business in 1978. Foley Waite Associates specializes in the fabrication of architectural woodwork and serves an exclusive high-end clientele in New York. He employs highly skilled, experienced craftsmen in wood and related materials. Mr. Conklin and his wife are lifetime residents of New Jersey. They currently live in Glenridge. And, Mr. Chairman, if you'll note during the testimony, if you haven't already read the testimony, specifically zeroes in on the question of transparency and where do our premium dollars go. So, Mr. Conklin, thank you for joining us. Mr. Chairman, thank you for allowing me to introduce him.
Mr. Conklin, the chair anxiously awaits the comment of the business gentleman from New Jersey.
Thank you, Mr. Chairman, members of the committee, Mr. Pasquale. My name is Kelly Conklin, and I'm here to talk about health care and its impact on small business. I'd like to make one thing clear right up front. I'm not a policy expert on health care, but I deal with broken policy every day in my business. I own with my wife, Kit, as the Congressman said, our business in Bloomfield, New Jersey. And my purpose today is to give you a window into small companies like mine and how the mess that is our current healthcare system impacts us. I'll start with some background, try to explain where we are, and finally lay out a few ideas as to where we might go. A little history. My wife and I opened Foley Waite in 1978 in a 700-square-foot shop in Montclair, New Jersey. In 1987, we expanded and hired 4 employees, and we started offering health insurance. The premiums were about 5% of our payroll, and we paid it all. Today, we employ 13 people, occupy 12,000 square feet of loft space, and serve some of the most influential people in the world. And we fork over $6,000 a month in health insurance premiums. That's 20% of our payroll, one of the largest single expenses in our budget. Why do I still offer coverage? Practically, it's necessary to attract and retain skilled employees, but I do it because it's the right thing to do for my people. It's the responsible thing, too. If I didn't offer coverage, I'd just be shifting cost onto someone else. We've got to stop pretending that we can escape this cost. It's a fixed cost. When responsible employers offer coverage and others don't, it creates an unlevel playing field. If I'm contributing for my employees and a competitor isn't, they have an advantage. We'd be much better off in a system where all employers contribute to a reasonable amount instead of this game of cost shifting. That's why I support a system of shared responsibility where employers pitch in their fair share. April is a month I dread, but not for taxes. Taxes are simple. I call my accountant. But health insurance renewal is a nightmare. Rising costs force us to cap our contributions for employees, coverage, and we're switching carriers each year. We had Horizon Blue Cross Blue Shield, but they just raised our rates 25%, so we're switching to HealthNet. That means new primary care physicians, and for my wife, who has a chronic illness, a new doctor who knows nothing of her medical history. It's very frustrating as the person who writes and signs the checks every month to know that a lot of that money we spend isn't going to health and it isn't going to care. My shopping for health insurance, my choice, is who is the cheapest this year. 3 years, 3 insurance companies. And over the past 2 months, as we transition to our new carrier, our premium bills are now $8,700 per month. While I'm writing the check for the new company, I'm paying the full freight for the old company. This is efficiency. This is not bureaucratic. This is cost effective. Really? The health insurance market has failed to deliver on its promise for small business. It fails to contain costs, enhance efficiency, or improve outcomes. It fails to provide coverage to millions, our dry cleaners, our corner store owners, Joe the plumber, and Al the mechanic. Something has to be done. I think transparency is critical. It's time to have the insurance companies come clean and say up front what's covered and what's not. It's time to assure everyone access to affordable health care based on shared commitment where employers like me, our workers, health providers, and the government all pitch in. We can take a big step by creating a public health insurance option. A well-designed public health insurance plan would finally give small businesses like mine real bargaining power, provide a guaranteed backup, and introduce greater transparency. Most importantly, by creating genuine competition and restoring vitality to the market dynamic, innovation in the private sector will occur. I'm not against private insurance. I'm just saying we need more options. As a cabinet maker, my trade, I think about it like this. A toolbox holds a variety of tools, each perfected to perform a specific task. You can't drive nails with a screwdriver or cut wood with pliers, and in my experience, when a critical tool is missing, well, things can get ugly. With healthcare, we've tried to do everything with a hammer. The public plan option is a critical tool missing from the toolbox, the one that could stem rising costs. According to the Commonwealth Fund, reform with a public option would save employers $231 billion between 2010 and 2020, and $3 trillion for the nation. Without a public plan, we lose 3/4 of that. Billions for the little guy. Imagine what we could do with that. I've read about ideas I can't support. I don't think new tax credits are the solution to this problem. I would rather have real health reform that addresses costs than a tax credit that will only be consumed by skyrocketing premiums. We don't need to fiddle with taxes or jigger the tax code. We need policies to stabilize a health care system in critical condition. I know I'm not alone. I'm a member of the New Jersey Main Street Alliance, a coalition of over 300 New Jersey businesses working for health reform that works. In a survey referenced in my written testimony, small business owners said 3 things. 1, we're willing to contribute, but we can't go it alone. 73% said they would. 12% said they wouldn't. That's a 6-to-1 ratio. We support reform that includes the choice of a public health insurance plan, 59 to 26%, 2-to-1. We want government to play a stronger role in making health care work, 70 to 16%, 4-to-1. Small businesses are looking to you for leadership. We need you to enact health reform that works for us and our employees this year so we can do our part for economic recovery. Thank you, Mr. Chairman.
Mr. Conklin, tell our friends in New Jersey, help us on the way.
Thank you, Mr. Chairman.
I'd like to yield to Mr. Camp to introduce our next couple of witnesses.
Well, thank you. Our next witness is Denny Dennis, who's a senior research fellow at the NFIB Research Foundation. And following that, we'll hear from John Shields, senior vice president of the Lewin Group in Falls Church. Thank you. Mr. Dennis.
Thank you very much, Mr. Chairman and Mr. Camp. This is an interesting day because Friday I start my 34th year at NFIB. I'd like to make 2 points for initially in my testimony. The first one is that employer-mandated health insurance, that's in the form of just funding premiums, pay or play, the payroll tax, they're all the same thing, they're all kind of a mandate, are bad for small business, they're bad for low-income people, and they're bad for the economy. Second point I would like to make is that health care costs must be addressed preferably prior to coverage expansion, certainly no later than simultaneous to coverage expansion, and hopefully not later than coverage expansion. As to the former, mandates are bad for small business because initially, and I'm going to underscore the word initially, in the short term, small business will absorb the brunt. Now, since there's a direct correlation between the amount of income that a small business owner takes from the business and his propensity to provide health insurance, namely meaning that if you take a lot out, you tend to almost always provide health insurance. If you take a little bit out, you tend not to provide health insurance. Under those circumstances, the abrupt necessity to absorb additional costs attack then the most marginal and vulnerable of employers. Same is true not only with low-income employers, but low-margin businesses. Second, we have a situation where an employer mandate effectively requires not only subsidization of low income, but also sometimes high income, which means it's a very blunt, instrument, and you're looking for a targeted instrument. And finally, it really embeds an employer-based system on smaller firms when an employer-based system clearly does not work for smaller firms. One of the things we're going to have to talk about is who the system works for and who it doesn't, and clearly small businesses it doesn't. Now, the employer mandate is also bad for low-income people because they're eventually going to have to pay for this. They pay for it in lost wages, they pay for it in lost employment, and they pay for it in other opportunities such as short hours. This is generally understood by economists. This isn't new. In fact, I cite several prominent articles in my written testimony. One of them is a very interesting one. It comes from the American Economic Review, 1989, written by someone I think most of us, or probably all of us in this room, have heard of, a fellow by the name of Larry Summers. Recently, there came an article in the Journal of the American Medical Association, JAMA, from some people we probably heard of, Ezekiel Aram and Victor Fuchs, which indicate the same thing, that this is all passed back to low-income people. And then thirdly, it's bad for the economy because it's essentially a regressive tax, a very regressive tax. And supposedly we're concerned in this day and age about income inequality, and we're going to try and add more cost on to lower-income people. So your choice is this when it comes to the employer mandate. Make low-income people pay for their health insurance effectively in a hidden, blunt, and politically easy way under the guise of employer money on the table, or you can subsidize the health insurance of the low income, target your subsidies, but do so in a politically more difficult way. Now, with regard to costs, and I'm sorry I'm using up my time, but I think we all agree that a major reason for the coverage problem is cost. I don't think that's in dispute. But what we're talking about here is a sequencing issue. Let's take a look at Massachusetts. Massachusetts took up coverage first, and now they're concerned with cost. So what happened? Between 2005 and 2007, Massachusetts cut its uninsured group rate by about half. I mean, there's some argument about numbers, but it's about half. Meanwhile, the entire cost of health care in Massachusetts rose 23%. The entire health care cost in the United States, comparatively, rose 11%. Now, if we do the same sequencing in the United States that they did in Massachusetts and have the same results that they had in Massachusetts, we're going to have a much worse problem because Massachusetts started out with a very low uninsured rate, much lower than the nation as a whole, plus they had a series of other advantages. So, your choice then is really to enact cost control reforms before or simultaneous to coverage, because after which there'll be a huge demand placed on the system for which there'll be no offsets. I thank you very much, Mr. Chairman. I would be more than happy to answer questions at the end, and also to go more into the employer-based system and why it doesn't fit small business very well. Thank you.
Thank you. Our next witness.
Thank you. Mr. Shields, you have 5 minutes.
Thank you. I'm the Vice President with the Lewin Group. We're a nonpartisan health management consulting firm specializing in health care. We don't advocate for or against any legislation. In President Obama's proposal while running for the presidency last year was to create a public plan that would be available to people who are self-employed and small businesses that want to offer insurance to their employees. Senator Baucus's proposal states that the new public plan would be similar to the Medicare program. And implementing the program in a manner that is consistent with Medicare has some huge implications. Somebody is supposed to turn on these screens, but if you turn to page 4 of the testimony, right now, payment rates for providers under the Medicare program are equal to about 71% of what private payers pay. For physicians' care, the payments are equal to about 81% of what private insurers pay. So you have a 25 to 30% lower price, lower premium as a consequence of that. In addition, there are some. There is administrative costs are lower under the program. For private insurance, for the private sector, insurance administrative costs average around 13.4% of claims. In the public program, we expect that the cost to be about 7% of claims. So we have a premium that is 20 to 30% lower than the premium that you have in private insurance today. And if you look at chart on page 5, average private coverage premiums right now are about $970 per month per family, for family coverage. That would drop to $7,600 per family if you were to buy it through this public plan. That's a savings of about $2,500 over the course of a year. So it's going to be a very attractive option. Lots of people are going to want to go into it. On page 6, we show what happens under the proposal. But to give it a little better context, the public plan has been proposed as part of efforts to expand coverage. One of those is a requirement that the employer either pay a tax or provide insurance. Also, President Obama's proposal included some expansions of Medicaid and some new tax credits to help people buy insurance. So we ran the model, did our estimates with those assumptions. If you look on the right side of the chart, we show, first of all, that there are about 28 million people who are uninsured today who would become covered under the program as a result of the program. That includes an increase of 16 million people on Medicaid. The public plan would cover about 132 million people. But most of that is going to be people dropping their private coverage and moving into the public plan. That's about 120 million people. That's 70% of the private insurance market. In our paper, we also looked at the impact if you were just limited just to small firms, and that's on the left side of this page. And in that case, if you limit it just to small firms, overall there's a loss of private coverage of about 32 million people. For employer coverage specifically, again on the right-hand side of the table, private employer insurance would go down by 107.6 million people. There would be an increase in the number of employers who are buying coverage for their workers through the public plan of 113 million. It's really a net increase in the number of employers contributing to the cost of the insurance for the worker. That derives primarily from the pay-or-play requirement, that you have to either provide insurance or pay a tax. So this is a very large shift away from employer coverage. On page 10, we have an estimate of what happens to provider income if we were to set up a program available to all firms using Medicare provider payment rates. Hospitals would lose about $36 billion in net income. Physicians would lose about $33 billion. If you limit it to small firms, actually hospitals come out a little bit ahead, and that reflects the fact that there's uncompensated care that's reduced by covering more people. So these are net figures, but covering everyone under Medicaid with other than Medicare payment rates would have a fairly substantial negative effect. The last thing I wanted to talk about is cost shifting. This is a chart on page 11 which summarizes the payment system for hospitals in the United States, and we've arrayed people by their source of coverage, and we've expressed the payments as a percentage of costs. Right now, in the middle, Medicare, actually in 2003, payments were equal to about 95% of costs. Medicaid payments were lower, about 89%, and then the uninsured accounted for a substantial amount of uncompensated care. To recover those shortfalls, the hospitals and physicians as well will increase what they charge private payers. Private payers were paying 122% of costs. And the key to understand here is that if you put more people in Medicare, where their payment rates are at this level, it will push down revenues for hospitals for those people and require the hospitals to increase their charges to privately insured people. If you look at the final page here, we estimate that if we were to set up a program where all firms can go in using Medicare rates, there would be a cost shift to privately insured people of about $526 per person, per privately insured person, approach maybe $1,500 for a family policy. But if you were to use, limit it to just small employers, small firms, the program would have less of a cost shift. In fact, because of the reduction in uncompensated care, there'd actually be a small reduction in the cost shift. So the point of the paper was to explain that there are different ways that you can construct this program. You don't have to use Medicare rates. You could use midpoints between private and Medicare. There are a number of choices, and in our study, we look at the impacts, all of these impacts, under those various several scenarios. Thank you.
Thank you very much. Now we hear from Gerald Shea, who's a special assistant to the President, John Sweeney, right?
Thank you, Mr. Chairman. I am Jerry Shea. I'm the assistant to John Sweeney.
Let me ask you this. Does the Service Employee International Union, are they working with the AFL in terms of monitoring what we're going through and seeing what labor think is best for their members?
Very closely. My last meeting yesterday was in a meeting with a number of unions, including both the service employees and the United Food and Commercial Workers, neither of which are affiliated with the AFL-CIO, as well as a number of the AFL-CIO unions and the NEA, by the way.
That's very helpful. We anxiously await your testimony.
Thank you, Mr. Chairman, and Mr. Camp. We appreciate the invitation to share our perspective based on the union's bargaining experience with 40 million Americans. And I'm honored, personally, to be before this committee. You have a tremendous responsibility in providing leadership on this crucial question, and I come with you both with a plea for help, which you've heard before, and also a pledge for cooperation and flexibility in terms of approaching this. We have to solve this problem this year, and in part, we have to solve this problem because even though the employer-based system, which is, after all, the backbone, as you pointed out, of our health care coverage and financing situation, has served us pretty well, it is really holding on by its fingertips. I can tell you that based on our experience monitoring bargaining situations across the country. This continues to be the most difficult issue in bargaining. I could give you examples today if I were free to share some confidential information about current large bargaining, where this is the only issue on the table and where strikes may ensue in short order in some very critical services because of this. It is true that large firms still provide coverage, but when you look beneath those gross statistics, you see that there is very substantial cost shifting to individuals. So that the studies are that the number of uninsured have gone, or the percentage of underinsured have risen from 15% to 25% over the past 5 years. Those are people who have insurance but can't afford to get the care that they're prescribed to get. So we're just seeing the erosion of the employment-based system. And even if you didn't want to do national health reform and cover everybody, we would need your help to stabilize that system, because it can't be done without government leadership. I am involved many, many hours a day working with employers and with other unions on ways that we can restructure health care to make it higher quality and more efficient. Those are very, very important conversations from our point of view. They're vital to the future of health care in this country. One of the clear lessons from that is we can't do it alone as the private sector. This has to be done by the private sector and the public sector, that is government, working together. So what are the elements of stabilizing employment-based coverage, in our opinion? One, it's controlling costs, because without controlling costs, whether you look at a private employment-based system or a public, say, single-payer system, without controlling costs, we can't afford the health system we now have. It is simply unsustainable for anybody. So that is priority number one in terms of employment-based coverage as well as other coverage. Secondly, you have to have everybody in the system. If you're going to continue, if you want to rely on the employment-based system, we have to have all individuals and all companies participating in the financing of that care. And then thirdly, government has to play the role of making sure that there are fair rules that are enforced across the board, and in our opinion, by sponsoring a public health insurance plan option. So let me just elaborate a little bit. First, on costs. Long term, we need to restructure the way we deliver and pay for care. The estimates from the Insurance Institute of Medicine are that $300 billion a year of what we spend go to care that is neither beneficial and sometimes downright dangerous for people. That is a lot of waste and inefficiency, and we know we can do better. We have shown in many institutions that we can reduce hospital-acquired infections. We have shown that we can reduce the readmission rates in a number of hospitals by taking certain proven steps. We have shown that we can reduce the horrific problem of mistakes in surgery by simple protocols, checklists, and timeout kind of procedures. We can do this. It won't be easy, and it won't be overnight, but we can do it, and that is the most important thing long term, because while there are a lot of ways that you could control costs in healthcare, we think that the best way and the most acceptable way to people in this country is going to be by improving the quality and efficiency of that care. Secondly, the point about including a public insurance plan plays in here. Mr. Shields has talked about the effect of a public insurance plan in terms of the savings that it could engender. We believe while there's a lot of policy dispute about the number of people who would shift from the private insurance to the public insurance sector, Mr. Shields has rather high estimates of that, in our opinion. There is clear understanding that this would reduce costs and save us money, so we think that's a critical step. On the issue of cost shifting, by the way, to the private sector, and this goes to the point about whether or not we should require everybody to pay, let me just give you our experience. Workers regularly trade off wages to keep health benefits. They make this decision on the ground every day, and their decision is consistently, we want health benefits, even if it means trading off wages, and in some cases, even trading off jobs. It's that important to American families for the simple reasons that you would all understand. We all hold the same position on this. So people want everyone to participate. They're willing to pay their fair share in this as long as everybody else does. And then lastly, the government must maintain the rules of the road for everybody. And we're starting this in a number of the quality improvement areas by requiring reporting on uniform national standards of quality and making that information public to inform both purchasers, individuals, and clinicians. And we need to extend that beyond this. So, Mr. Chairman and Mr. Camp, I appreciate the opportunity to appear before you. I just want to make one last point, if I could, and that is that the idea of taxation of health benefits has come up as a way to raise money. And I just want to say, going back to my point about what we need to focus on here is stabilizing the employment-based system. If we were to go to taxation of benefits, that would be the ultimate destabilizing step we could take. You may consider the employment-based system an accident of history in the United States. We heard some of the history from Dr. Gould. It is, however, composed of several core elements, one of which is the tax-preferred treatment of benefits. You take that away, and you're really pulling the rug out from under this system. Now, maybe you want to change the system altogether. There's lots of proposals to do that. But this taxation of benefits would certainly destabilize it. And in terms of the public support for health reform, asking people to pay again for the health insurance they already think they pay an enormous amount for is not going to wash. This is not going to get public support. It's going to get tremendous public opposition. So I would just caution against going down that road. Thank you, Mr. Chairman.
Mr. Sweeney. Let me make it clear. I want to thank the panel and to make it abundantly clear that we recognize that you're not Republican and Democratic witnesses. It's just who invited you, but we know that all of you are concerned about improving the health care of Americans and they get access to affordable health care. I don't think it's necessary to say that, but I just want to make the record clear as I tear into Denny Dennis, the Republican witness. Mr. Dennis, you made it abundantly clear that cost is a factor in terms of people having access to health care. We have, I guess, 45 million people, half of which work every day. And if they have a serious illness in this great country of ours, they got to get care. You agree? Where would they get this care?
Where would they get this care today?
I mean, they are going to be treated. They have swine
certainly
flu,
are.
colds, broken legs. They don't have insurance. They work hard every day. The employer loves them but can't afford health insurance. Where do they get it? They're not just, they don't ask whether Republican or Democrat. They say, have you got insurance? They say no. There's some moral mandates that people have to take care of these people, especially at our hospitals, especially in the emergency rooms.
Correct.
What do we do with these people? Do we allow them to continue not to be insured? They don't pay for it. The taxpayer pays for it. What would you suggest we do for them?
Well, one of the things that we've suggested as far as smaller firms are concerned.
No, I'm talking about the employee. He is right now, as you and I talk, working every day, scared to death the kids are going to get sick. He can't afford insurance. Employee can't afford insurance. And they are here in large numbers, millions of people. So we can't ignore them if we're talking about universal coverage. But for you, recognize and cost, what do we do?
Well, in terms of making sure that they have coverage and care, yes, they do. The question becomes who's going to pay for it, and that's the issue. There are certainly better ways to deliver care for the low-income folks who are uninsured than we're doing it today. We're doing it through emergency rooms. Why aren't we doing it through clinics? There are a whole series of...
Well, your contribution would be expand community health care clinics.
Well, I'm suggesting that would be, there are several steps that we could take, Mr. Chairman.
Well, that's what we're here for.
Okay, I would be...
Because we have a serious problem. It's going to cost money. Many of us truly believe that the facts yell at us that it's going to save money. They kind of believe, and I'm no doctor, neither are you, that if these people have preventive care, have examinations where they're tired of hearing you should have come earlier, now you have to be admitted to the hospital, which is the most expensive type of care. But if they knew that their kids could get examinations, if they knew they had dignity to ask the employer, I got to go for my checkup, you just don't have to be a scientist to know you're saving money. And as a patriot and the chairman of this committee, to me it means they're healthy, they'll be working, they'll be paying taxes.
Yes, Mr. Chairman, we have given the committee staff, we had a study done for us by Professor Rossiter at William & Mary to look at costs, precisely places that we can go to save costs.
Where?
And, well,
I've already said, and you're not going to contradict, that 48 million people that don't have health insurance, if we give them, overall, the country's got to save money. Forgetting productivity and all that economists talk, we got to save money in terms of them not costing society. health care that they don't have insurance to pay for. What I want you to do is not to admit that we have a problem, but we are mandated today to move forward and resolve this problem. And we just need your expertise to say, if I tell you that one of the things we're considering is having a public plan,
Yes,
and if the employer has a plan, you keep it if you like it.
yes.
But if indeed you got a precondition, you can't get in the plan, or it's too costly, that the government would say, this is backup.
Yes.
This is backup for you, and you got to do it. Could you go along with it? Could
No.
you- No?
No, not with that particular proposal. What we would suggest instead is we have something like the Massachusetts
Forget
plan.
Massachusetts. Tell me how it works.
Well, essentially what we have is something called a connector. And what that does is it allows, they're bringing in small business, but essentially it provides a central clearinghouse, if we want to talk about a clearinghouse, where insurance companies register their plans, and people can go to them, particularly smaller folks can go to them, individuals can go to get their insurance, and so it's like a big central marketplace.
And the
nice,
governor mandates that the employers must insure these people,
No.
not with compassion.
no, it doesn't.
I understand
And-
that's the Massachusetts plan. That
Doesn't-
is an employer mandate.
Well, it's $295 worth of
I don't care what
employer
it
mandate.
is. I'm saying the
But-
employer has to provide
No.
insurance for an employee under
No,
the
I mean, there's-
Massachusetts plan.
Why would you want to put people out of work? I mean, why would you want to depress wages? There's got to be a different way to approach this. The question becomes, there's an interesting issue here. It's called, we use the politically really nice term of shared responsibility.
You using it.
I'm just bringing it up. I'm not using it. I'm saying I don't know what that means. I know what.
You
a lot
don't
of people-
have to know. I didn't raise it. You can argue with yourself what it means. I am saying that
Okay.
we have to do something, and you're suggesting I don't know what.
No, I'm
But
not
we're going to
suggesting.
take care of these people, and if you don't help us to do it, we may have a way to do it that you don't like.
No,
But
I
we're
am-
going to say that the employer has a responsibility, and the employee has a responsibility, and the government has a responsibility. And we're not going to Massachusetts. We're staying right here and hammer this thing out. So when you think of something that you say, well, that makes some sense, I don't agree with it all, then come back and we'll talk.
Well, let me say, Mr. Chairman, that the pooling and the whole idea of getting rid of being able to rate on claims experience and that sort of thing, which is all inherent in the system I'm talking about, is certainly very much directed towards the type of thing that you're talking about. After all, the state cut its insurance or its number of uninsured by half. That certainly gets to, I think, what you're looking at, isn't it?
Full coverage.
So I think, well, it'd be nice, yes. But at least we're moving in the right direction. This is clearly, I think, a very positive suggestion. And we know that there are other kinds of things that can easily be done. Excuse me, I'll take that back. I'll get rid of the word easily.
Bet you
The other things that can be done to lower costs, which will bring in more people into the system. So I think indeed that we're proposing some very positive steps to directly go after the kind of concerns that you have.
Well, would you write an addendum to your written testimony and spell out what you think those are? And by unanimous consent, I'll have it put in the record. And once I see what your ideas are, then we'll get back to each other. But it's not easy. I yield to David Camp.
Well, thank you, Mr. Chairman. Thank you all for your testimony this morning. Mr. Shields, in your testimony, you mentioned that if a new government-run health plan paid providers at private market rates, the premiums in the government-run plan would be 6 to 9% below those in the private market.
Yes.
And you cite the reason for that as being higher administrative costs in the private sector. And this has been a discussion we've had in the committee over many months about comparing administrative costs between the government and private sector health programs. And my comment is I believe that's an apple to oranges comparison. There are many programs that significantly improve the health and well-being of those in private health coverage that I believe are considered administrative costs. Disease management programs, 24-hour nurse helplines, I think those serve critical functions, but they're considered administrative costs in this comparison that often occurs. And private plans also spend money building provider networks, which can provide and can improve access, for example, to top quality providers and exclude poor performers. And so this provides real value to their employees, but also falls into the category of administrative costs. And similarly, anti-fraud programs, which help reduce the costs of health care, I think those are relevant in private health plans, while government-run programs like Medicaid and Medicare have pretty poor records on fraud and abuse. In fact, there was a recent article in Congressional Quarterly, and it found that, and I'm quoting, "The government has never done a particularly good job detecting fraud in Medicare, much less preventing fraud in the first place. Most claims are never checked at all." But these anti-fraud programs and other costs are also considered administrative. So I would ask unanimous consent to submit for the record a letter to the editor in the Wall Street Journal, which was written by the former administrator of CMS, that highlighted some of the problems of trying to compare administrative costs between Medicare and private health insurance. And I would just like to ask your comment on that.
Sure. There are utilization management functions that most private health plans have. Pre-certification you might find on your insurance card. You've got to call in and get permission to go get an MRI. You've got to get permission to go to the emergency room and so on. Those things are estimated to save costs between 4 and 8%. Our own study came up with something in the neighborhood of 4%. The numbers we have on on the cost of services are adjusted in here to reflect that roughly reflect that adjustment. So so that we're not really counting it. We're counting it where I think you should count it, which is the cost of the utilization. The administrative costs are what they are, but then the differences in utilization and the impact that has on the premium is also part of it. So it accounts for that very roughly. I can't say it roughly accounts for it.
And Mr. Shields, Lewin Group has done work for hospitals, physicians, but you've also done work for the Economic Policy Institute, who's testifying here today, as well as for the Commonwealth Fund. Is that accurate?
That's right.
All right. Mr. Shea, would it be a fair statement to say most of your members would like to keep what they have?
That would be a fair statement, sir.
And would it also be fair to say that Medicare-like coverage would probably not be an acceptable replacement for the level of benefits that most of your members have now?
We cover many retirees, including Medicare recipients, Mr. Camp, and we usually supplement the Medicare benefits to bring them to the standard of what the active workers get.
And but particularly your non-retiree members would find a Medicare-like plan to be significantly below the benefit level they're receiving now. Would that be fair to say?
We strongly believe that that with a public plan you need to allow for a private insurance role or private union fund role.
Yes.
Would supplement or compete with, yeah. So you'd want to have something not just a public plan.
Yes, but comparing the two, a Medicare-like plan has the plan they have now has a much higher benefit level than a Medicare-like plan. I think we pretty much...
That's true, and widely, for many years, people have said, if we were to extend Medicare to other people, you'd have to raise the benefits and modernize them.
Yeah, and so that for your retirees, as you mentioned, you use a supplement. Thank you. Thank you all for your testimony. I yield back the balance of my time.
I guess I'm next. It's interesting, Mr. Shields, that when Mr. Camp asked you about the administrative costs and said that you were comparing apples and oranges. I think your answer was you're not.
We've,
I mean,
yes, okay, you're correct. I would say that's correct.
okay. So I don't think we can just pick and choose when we like your results and when we don't. But I think we can question some of your assumptions. In terms of what would be the transfer from employer insurance to a public plan, because as people thought about transferring, the private sector might well respond to competition, to competing with the public plan, right?
Yes?
And so therefore, the private plan might become more effective, right?
We expect improvements, but we don't think that they will be able to, most plans won't be able to survive in that environment. The ones that will survive will tend to be integrated systems, HMOs, and where, for example, some of these HMOs own their own hospitals. They don't have to worry about the cost shift.
But let me ask you this. If you look at employer plans in the construction industry, which I used to know something about, you assume that the employers would shift to the public plan in mass?
If based on the price of the coverage that they'd be offered, it differs a little bit by firm size, but we basically figure out what the cost of insurance is in today's market for individuals, which is kind of an involved process, and then we figure out what the cost of the plan is, public plan, and then we use models of how people respond to changes in the relative prices of health care to figure out how many people go into the public plan.
Okay, but these employer-based plans are controlled by collective bargaining agreements, aren't they?
Well, 16% of...
I'm talking about in the construction industry.
In the construction industry, I believe that's correct, yes.
And your assumption is there'd be a massive shift, that they're subject to collective bargaining agreements, and that the employee representatives would decide to shift to a public plan?
Yes, there's two things to consider. First of all, in a competitive environment, you would want, you almost have to. I mean, if your competitor uses the public plan and is saving $2,500 a year for family coverage, then you're going to be at a competitive disadvantage unless you do the same thing.
Of course, if...
Well, also, I just want to add that we just heard Shay point out that workers explicitly make these trade-offs between cost and benefits. And it seems to me likely that when a family has a chance to save that kind of money, the workers may develop a considerable demand for the change as well.
Okay, though one plan might be better than the other.
Yes.
Your figures assume that there would be a major reduction in the uninsured, right?
Yes.
Over 5. Mr. Dennis, just to pick up what our chairman was saying.
Yes.
I reread your testimony, and the problem is you don't like a mandate, you don't like a public plan, but you have no plan. I mean, and the problem with the opposition here, they don't like a public plan, they don't like the mandate, they have some other complaints, but coming up with a plan that will clearly reduce the uninsured of close to 50 million people in this country, there is no plan. And I think you should take up our chairman's offer. I have your small business principles, but I think what you need to do if you don't like the mandate and you don't like the public plan is to come forth with a very specific proposal that would assure that there would no longer be 50 million uninsured in this country, and that in a reasonable period of time, the number would be essentially zero or close to that. Because otherwise, simply trying to slug it out by critique doesn't work if there is no alternative. My time's up.
Mr. Herger from California.
Thank you, Mr. Chairman. As you know, at last week's hearing, Ken Sperling testified on behalf of the National Coalition of Benefits. The chair asked about the coalition's view on a government-run plan. Since then, members of the National Coalition of Benefits Steering Committee, who collectively represent hundreds of employers that sponsor health benefits for tens of millions of Americans, sent a letter to you stating their position on a government-run plan. In part, the letter says, quote, proposals to have a public plan compete in the private marketplace are of grave concern to employers who provide health insurance coverage. The public plan's unfair competitive position, both by size and regulatory authority, will merely shift costs to the private sector and employees covered by private plans. The letter goes on to say, Medicare's underpayment results in private payers and the people covered by these plans making up the shortfall and increases the cost to employers of providing quality health care coverage. A public plan option administered by the federal government is inherently destabilizing to employed-based health insurance benefits, close quote. Mr. Chairman, I would ask unanimous consent to enter the letter into the record.
Without objection, Mr. Herger.
Thank you very much. Mr. Shields, you estimate that a government-run health plan paying Medicare rates would mean a $36 billion cut to hospitals and a $33.1 billion cut to physicians, and that's just in 1 year. Since it's paying below market rates, the government-run plan could charge below market premium. But while the government-run health plan might be cheaper, it doesn't mean it will be better. I worry that people enrolled in the new government-run plan may find themselves with health coverage but without access to care. Today, half of physicians are no longer accepting Medicaid patients, and 28% of Medicare beneficiaries searching for a new primary care physician are having a problem finding one. Wouldn't a public option, that is a government-run plan, paying providers Medicare rates only exacerbate access to care problems?
I think you're correct. It would make it much more difficult for the providers. It's fair to say that our numbers are showing that the physicians under this plan and hospitals will be providing more services to more people for less money. And it's hard to imagine you can do that without something bad happening somewhere. I think that we spend enough on healthcare in this country that through efficiencies we could get by on that level of spending. The question is, will the system actually give us those efficiencies? Or will it simply, as you say, cause some providers to stop seeing privately insured, the members of the plan and so on? I don't think there would be a wholesale rejection of the plan by providers, however, because so many people would go into the public plan. Who would you care for? If you didn't accept Medicare, who would you care for? There'd be 120 million people in it, 132 million people in it plus Medicare itself, so that's 170 million people. I don't think any provider is going to be able to walk away from what is probably 60-70% of the whole marketplace that way. Providers will have to somehow do it within the amounts that they're being paid. Whether that compromises the quality of care or not is an open question. It could be done in ways which are bad for patient health. It could be done in ways, if we're careful, where it does not impact patient health so seriously. But it's very hard to imagine taking this much money out of the system, while at the same time increasing demand for services without something bad happening somewhere. So I guess that would be my answer, and not terribly specific, I apologize, but that's
Let me thank you and the panel and tell you where we are. The bells that you heard mean that we have to respond. The budget bill is on the floor. It'll take 15 minutes, roughly 10 left to answer that. Then 2 suspensions are there. That's roughly 5 minutes. And so if we could suspend and all return at 12 o'clock, I apologize to the panel for this break, but you might be able to get something to eat. Then we'll come back, start promptly at 12 o'clock, and we'll try to proceed as expeditiously as possible. Thank you. We adjourn until 12.